Hi everyone, my name is Maliha Butt and I am PGY3 Internal Medicine resident at Altman Hospital in Canton, Ohio. The topic of my presentation is collateral or culprit, an unexpected finding of coronary artery fistula during evaluation of aortic stenosis. I am grateful to all my co-authors for their contributions and they are as listed here. And let's dive into this presentation. Coronary artery fistulas are rare cardiac anomalies that are mostly congenital. They are often incidentally found on imaging, but they can also be responsible for myocardial infarction, heart failure, pulmonary hypertension, and even cardiac tamponade. We present a patient with dyspnea who was found to have coronary artery fistula during evaluation of aortic stenosis. Our patient is a 69-year-old man who presented with intermittent dyspnea and fatigue for 2 months. His initial evaluation shows no evidence of acute heart failure. Labs showed normal CBC, liver, and renal function. Transthoracic echocardiogram revealed severely calcified aortic valve, as seen here on the parasternal long axis view. The mean gradient across the valve was 11 mm mercury, with peak velocity of 2.2 meters per second. Valve area by peak velocity was 1 centimeter square. Right heart cath showed normal hemodynamics. Left heart cath showed moderate disease in the right coronary artery, as seen here. It showed no significant disease in the left coronary artery, but it did show an interesting finding of LAD to PA fistula, which is better seen on the far view. This image shows a pacification of the pulmonary circulation after a few injections of contrast dye. Interestingly, we found a CT chest angiogram for this patient from over 10 years ago, which showed the same fistula. As this fistula had been present for over 10 years without any complications, we presumed that the patient's symptoms were more likely due to the moderate to severe aortic stenosis. We elected to continue workup for possible transcatheter aortic valve replacement and consider a fistulogram to further evaluate the fistula if symptoms did not improve with treatment of the aortic stenosis. Coronary artery fistulas are present in about 0.9% of the general population and are responsible for 0.13% of congenital cardiac diseases. Less commonly, cardiovascular interventions such as coronary angiogram and valvular interventions, as well as myocardial infarction, chest radiation, or chest trauma, and autoimmune diseases like Takayasu arteritis or Kawasaki disease may also result in coronary artery fistula. Coronary artery fistula is often asymptomatic, but may lead to complications such as myocardial infarction due to Steele syndrome, or right ventricular failure due to pulmonary loading, etc., depending on the type and site of fistula, shunt volume, and the presence of other cardiac anomalies. Diagnosis is made with coronary angiography or coronary computed tomography angiography. A recent study by Jing Li in 2019 showed that CCTA was superior for the diagnosis of coronary artery fistula and the delineation of its anatomy compared to a traditional angiogram. Treatment of coronary artery fistula is with surgical or percutaneous intervention, such as coiling or ligation. Current guidelines recommend treatment for all proximal segment fistulas due to the increased risk of aneurysm and rupture, as well as all large fistulas, moderate to small fistula with symptoms, or significant left-right shunt. In conclusion, Coronary artery fistula represent a rare cause of dyspnea that is diagnosed with left heart cath or CCTA and requires intervention if clinically or anatomically significant. Thank you very much for listening to my presentation.